Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Thank you for joining us for ACC conference coverage, Clinical Clips in Heart Failure. My name is Peter Toth, and I'm the Director of Preventive Cardiology at the CGH Medical Center in Sterling, Illinois, and also Adjunct Professor of Medicine in the Division of Cardiology at the Johns Hopkins University School of Medicine. In this clinical clip, I will provide expert interpretation of the latest advances in the treatment of heart failure presented at the 2024 American College of Cardiology Conference in Atlanta, Georgia. There were some remarkably interesting abstracts presented at ACC in the area of heart failure, and I'd like to take you through 6 of the more interesting ones that I found particularly useful clinically. Our first abstract is one by Asim Khan and co-workers, and it is a meta-analysis of randomized clinical trials looking at the impact of SGLT2 inhibitors in acute decompensated heart failure. 8 studies were included, and the results are pretty remarkable. If you look at the impact of SGLT2 therapy on major acute coronary events, the authors found a 36% relative risk reduction. For 90-day all-cause mortality, a 62% relative risk reduction. There was no impact on renal dysfunction, and there was also no increase in risk for urinary tract infection. And obviously, this is a long-standing concern for clinicians because the SGLT2s do waste glucose out of the glomerular ultrafiltrate and into the bladder, where, of course, it might function as a culture medium, but clearly this is not as common as some people might think. In total, just under 2,500 patients were included, and I emphasize that early initiation of SGLT2s in acute congestive heart failure was associated with significant reductions in MACE, 90-day all-cause mortality, and also a 38% reduction in heart failure readmission compared to standard medical therapy alone. Again, no renal complications between the 2 treatment groups, and in fact, the SGLT2s have shown significant benefit in the setting of chronic kidney disease, and hence the authors concluded that early initiation of an SGLT2 may be safe and effective in acute congestive heart failure and improves 90-day all-cause mortality and reduces heart failure readmissions without increasing the risk of acute kidney injury or urinary tract infection. And of course, anything that is going to be reducing not only heart failure readmission, but also mortality and MACE certainly needs to capture our attention. Our next study is rhythm heart failure. Now, this is amazing because actually it represents a novel characterization of mechanisms of death in heart failure. So often we assume that patients die suddenly in the setting of heart failure because of tachyarrhythmias. And Beggs and co-workers out of Scotland looked at this issue and clearly felt it was time to determine whether or not this was true. The study was fascinating because all patients were implanted with a means by which to monitor heart rhythms. They enrolled 257 patients with heart failure. They noted 105 deaths during the course of the trial, and they were able to capture 58 terminal rhythms. 40 of the patients also underwent autopsies. When we look at the clinical endpoint committee adjudicated heart failure deaths, 16 patients underwent autopsy, and it was found that 2 patients experienced an MI, 1 patient had a pulmonary embolism, and 13 patients were deemed to have died from complications stemming from heart failure, including tachyarrhythmia, non-tachyarrhythmia, and then also 1 patient in whom it could not be determined. Among adjudicated sudden deaths, 13 patients underwent autopsy, 3 of whom died of an MI, 2 from a pulmonary embolism, 1 died of non-cardiovascular causes, and the remaining 7 had autopsy negative sudden cardiac death, with 3 having tachyarrhythmia and 4 having non-tachyarrhythmia. And we see examples in the right panel here of patients who died, and clearly they did not have tachyarrhythmias, ventricular or otherwise, and they were actually bradying down. So this is the first study to systematically characterize mechanisms of death in heart failure. Again, 105 deaths among 257 enrolled patients. The terminal heart rhythm was captured in 58 patients' autopsies in 40. Of 29 deaths adjudicated to sudden cardiac death, non-tachyarrhythmic terminal rhythms were equally as common as ventricular arrhythmias. In sudden cardiac death patients with a ventricular arrhythmia, triggers of death identified at autopsy included MI, pulmonary embolism, implicating potentially reversible substrates for ventricular arrhythmia. In SCDs with a negative autopsy, non-tachyarrhythmic terminal rhythms were more common than ventricular arrhythmias. Of 30 patients adjudicated as experiencing pump failure death, potential pathological accelerants of death identified at autopsy, as mentioned, included MI and pulmonary embolism, implicating potentially reversible pathology. Fascinating. Finally, description of pathological triggers of ventricular arrhythmia-related sudden death, suggesting possible treatment pathways. Demonstration of terminal rhythm does reliably associate with pathological cause of death. And description of a previously uncharacterized phenomenon that refutes conventional assumptions, sudden cardiac death with a negative autopsy where the terminal rhythm is not a ventricular arrhythmia. Now let's take a look at the real-world place and clinical predictors of vericiguat for heart failure with reduced ejection fraction. And this is a very fascinating poster by Haddad and coworkers. And this was performed in a tertiary academic care center. We see on the left side the patient baseline characteristics, heart failure class, etiology of the heart failure, left ventricular ejection fractions, and the comorbidities, including hypertension, dyslipidemia, diabetes, chronic kidney disease, atrial fibrillation, and coronary disease. We also notice that quadruple therapy adherence in this particular tertiary care center was really pretty good. You'll notice that for ischemic cardiomyopathy, non-ischemic cardiomyopathy, beta blockade was highly utilized. The use of valsartan with sacubitril, also about 2/3 of patients. ACE inhibitor, ARBs, reduced between around 7 and 10%. But if you're using valsartan with an atrial natriuretic peptide sustainer, then clearly you're using a better drug compared to ACE ARB alone. Mineralocorticoid receptor antagonism, again, really at optimal dose, about 2/3 of patients, and an SGLT2 inhibitor optimal dose anywhere from 3/4 to about 80% of patients. So these patients were really well treated, and we see the split between ischemic and non-ischemic etiologies on the right for heart failure. And other etiologies included valvular disease, tachycardia-induced, infiltrative, inflammatory, and toxic. We see that for patients, the use of beta blockade and quaternary use of medication, quite good. So how about quadruple therapy at target doses? 47%, quadruple therapy with angiotensin II receptor antagonism and an aprolacin inhibitor, 57%, quadruple therapy, 64%, triple therapy, 74%, and optimal heart failure, reduced ejection fraction therapy at about 2/3. This is really pretty good. You don't see numbers like this very often in the setting of heart failure, unfortunately. And you'll also notice that history of hospitalization for heart failure between the ischemic and non-ischemic cardiomyopathy groups is pretty representative. So what they see? Well, hospitalization for heart failure within 12 months was noted in about 1 in 4 patients. No statistically significant difference in heart failure hospitalization rates between ischemic and non-ischemic cardiomyopathy. Interesting. Overall, 135 patients were on optimal pharmacological therapy for heart failure with reduced ejection fraction, and 27 patients were eligible for vericiguat. Now, 6 patients had an indication for vericiguat but were considered ineligible due to contraindications. 3 had CKD with an estimated glomerular filtration rate less than 15, and 3 had a systolic blood pressure less than 100. Now, recall that vericiguat really does very well, augments risk reduction for the dual endpoint of mortality and hospitalization for heart failure among patients who are less than 75, patients who experience a recent reduction in left ventricular ejection fraction, worsening of heart failure, or recent admission to hospital for recurrent heart failure. Heart failure etiology does not predict vericiguat eligibility, and brain natriuretic peptide levels in patients eligible for vericiguat was significantly higher than in non-eligible patients, and I think this is a pretty reasonable finding. Here you've got a very high percentage of patients on quadruple therapy, and the question is, how do we best configure vericiguat? Is it the sickest patients? Is patients who are experiencing progression in heart failure? And obviously, if patients have higher NT-proBNP levels, they're sicker, their heart failure is accelerating. CKD was significantly associated with increased odds of vericiguat eligibility, and left ventricular ejection fraction was an independent predictor of vericiguat eligibility, and that should come as no surprise. 13.5% of patients with heart failure with reduced ejection fraction followed at the heart failure clinic were eligible for vericiguat over the previous 12 months of follow-up. And obviously, there is a correlation between vericiguat eligibility and higher levels of BNP, lower left ventricular ejection fraction, and CKD, which is exactly where currently vericiguat is positioned. There are numerous other trials underway to see where else to configure vericiguat, but right now that appears to be a very reasonable approach. Vericiguat eligibility remains difficult to predict, and 2/3 of heart failure patients with reduced ejection fraction are under optimal pharmacological therapy per the AHA, ACC, and Heart Failure Society guidelines, which at this medical center really is pretty good. Now, how about what's the impact of a pharmacist using telehealth to try to improve medication adherence in the setting of heart failure and see if this improves hospitalization for cardiac etiologies? And the answer is, it sure appears to. Here is a study by Chen and co-workers looking at whether or not a pharmacist communicating with patients via telephone improves adherence and improves heart failure hospitalization rates. If you look at patients who are on 4 guideline directed medical therapies, look at this, compared to patients who did not receive telehealth assistance from a pharmacist, 39 versus 12%. That's a huge difference and a very important gap to close. And if you look at all-cause hospitalizations, definitely a very nice trend toward reducing this. And then if you look at cardiac hospitalizations, a very substantial reduction for patients who received a pharmacist telehealth collaboration in terms of medication management. Very impressive data. So when we look at this numerically, what did assigning a pharmacist to a patient do? Well, the odds ratio for being on optimal goal-directed medical therapy with 4 drug classes is 2.27. I'll take that any day. All-cause hospitalization, not statistically significant, but clearly a 28% trend. But cardiac hospitalization, statistically significant, and a 74% relative risk reduction. Now, who wouldn't take that? What health system wouldn't take that? Clearly, the virtual pharmacist co-management of heart failure patients with reduced ejection fraction achieved rapid improvements in GDMT optimization, dramatic reductions in cardiac hospitalizations at 6 months, with little effect on all-cause or cardiac ED visits. The bottom line is, to do this in just 6 months very clearly shows you the impact of following the guidelines and making sure that patients are on 4 medications that improve heart failure outcomes. Okay, now here is another study looking at the Optum database, which included just under 108,000 patients by Morris and coworkers. They looked at what correlates with adherence to guideline-directed medical therapy in patients with heart failure with reduced ejection fraction. We see here the demographics of the study, and being Optum, it is widely representative of the United States. We see education level, household income, as well as comorbidities. And it's interesting because age over 70 correlated with better long-term adherence, male gender with reduced. If you were African American or Hispanic, you had reduced long-term adherence. And if you had Medicare insurance, that had some of the best long-term adherence, interestingly. And if a patient had previous peripheral vascular disease, better long-term adherence, chronic kidney disease, better long-term adherence. Now, in terms of 3 and 4 guideline-directed medical therapy combinations, you notice it's pretty tight. And there's not a whole lot to say here other than in some ways, there really isn't much difference. Now, this is Greg Fonaro's group, and they just do a fantastic job with this. Look at this in terms of individual medications: beta blocker, ACE inhibitor, ARB, valsartan with a naproxen inhibitor, mineralocorticoid receptor antagonist, SGLT2 triple therapy, quadruple therapy. Now, this is community-based data, all right? So we saw what happened in a tertiary medical center. Now the numbers get a little discouraging here, because when you look at beta blockade, beta blockers are cheap. There is very high level of use, 76%, and adherence in terms of 80% usage, 80% of days with patients taking the medication, 71%. Wow, that's pretty good. Now for ACE-ARB, medications are generic, cheap, 61%, and 80% adherence at 70%. Now, when you go to ARB with the naproxen inhibitor, 19% with 61% long-term adherence. Mineralocorticoid receptor antagonism, despite the fact that spironolactone is also very cheap, 26%, 68% long-term adherence. But now here's where things bottom out. And SGLT2, despite the fact that these medications are enormously beneficial in the setting of heart failure, 12%, still dramatically underprescribed, and a 66%, 80% adherence rate. Now, how about triple therapy and quadruple therapy? Oh my goodness, here we have a problem. 12% for triple therapy with only a 45% adherence rate. And for quadruple therapy, 2%. There is a long way to go here. And obviously, when you're talking 12 and 2% for triple and quadruple therapy in a database as representative as Optum, these are extremely poor numbers. So Clearly, there's heterogeneity in guideline-directed medical therapy use in the U.S. population, with lowest use among newer GDMT medication categories like the ARNIs and the SGLT2s. Adherence is lowest for the MRAs and newer medications. The newer ones obviously are more expensive. Also, utilization of triple and quadruple therapy low, and adherence to these were suboptimal. Factors consistently associated with adherence to individual and combination GDMTs were race, region, and history of diabetes. Medicare insurance have the strongest association with adherence, and identification of patient characteristics associated with adherence to GDMT, including quadruple therapy, stress the need for tailored management strategies to help improve outcomes in this patient population with high unmet need. These data are pretty discouraging, and we really need to ante up and help these patients understand why these drugs are so important, why adherence is so important, and what each one of these drugs, how they impact morbidity and mortality, and perhaps then we can increase long-term adherence rates. Now, last but not least, heart failure and impaired cognitive function. This is based on a National Health and Nutrition Examination Survey by Fioramonti, Gorchow, and co-workers. They looked at 5,951 patients who were 60 years or older, and 412 of these in the NHANES database were found to have heart failure, so 7.4%. We see the demographic features of these patients off to the right. And of these, 199 were female and 213 were male. The incidence of heart failure in this analysis cohort was similar to that of the wider U.S. population, and that is typically true of NHANES since it is broadly representative of the entire U.S. population at a given point in time. We see here that in multivariate analysis that there are a number of things that correlated with the combination of heart failure and impaired cognitive function. And these included race, education clearly correlates and has been shown to correlate in many, many studies. And then there's also a correlation with not having dyslipidemia, not having hypertension, and then there is a correlation with having depression, a prior history of a stroke, and alcohol consumption. So what they see? Well, what they did was they had each of these patients perform the digital symbol substitution test. And this DSST, it's basically a paper and pencil cognitive test. It's on a single sheet of paper. It actually has better validity than a mini mental status examination. And it requires that a patient match symbols to numbers according to a key located on the top of the page. Each patient copies the symbol into spaces below a row of numbers. And what they found was that for patients with heart failure, the DSST score was in fact lower than patients who didn't have heart failure. And the authors conclude that cognitive impairment is more common amongst patients with heart failure. The lower scores noted for the patients with heart failure is within the range of mild cognitive impairment, a validated pre-dementia stage. Obviously, more research is needed in this area, but some of the hypothesized reasons for impaired cognitive function would include reduced cerebral perfusion, the loss to some degree of autoregulation, perhaps intracerebral vascular inflammatory change, and others. Thank you again for joining us for ACC conference coverage, Clinical Clips in Heart Failure.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.